Now, it's got the flush out.
Yeah, we can try.
I'll try it. I'm like, I don't know. You know, we're back to. Like that. That's basically like when they show up. This dash is date. I don't know, like. Oh my goodness.
Oh.
I'm just. Fine.
Yeah. Sometimes like. It's like I just.
I don't like this.
Too easy. Don't play that.
It's
Like I'm young.
Even they won't.
Introduce you to that. We will, people, I'm sure will start from.
Oh, yeah.
Okay, well, we'll go ahead and get started because Dr. Lubner does need to catch a train later today. For those of you lucky enough to attend this noon conference today, she spoke on Reading Spaces. Dr. Lubner did her undergraduate medical school at the University of Wisconsin-Madison, then went on to do her residency and fellowship, or residency rather, where she's chief resident at the Mallinckrodt Institute of Radiology in St. Louis, and then returned to her home and where her heart is in Madison to finish her fellowship and join the faculty. She is a rock star. She rocketed through the ranks to become a full professor at the earliest stages. She's on faculty at the AIRP, and she has published over 200 articles, really a role model for what an academic radiologist is. One of the things that she's been able to really do well and distinguish herself nationally is in the role of CT acquisition, image-guided procedures, and what she's going to talk about today is protocol optimization, which is really important for our team to learn from. We're lucky to be joined by many of our CT technologists and medical physicists, so I'm sure they will learn a lot from you. On a personal note, she's a huge Wisconsin Badgers fan, and I said earlier that they gave rise to Dick Bennett, who gave rise to Tony Bennett, so there's a linkage there between Wisconsin and Virginia. We overlapped for 2 years through our research program where I got to know Meg well. And the only thing that she's better than radiology is just her kindness and genuineness. She is the ideal of that Midwestern person that everybody falls in love with. And I really consider it an honor to count her as a friend and as a former colleague, and excited to hear from her today and learn from her on what we can do to learn from her lessons in CT optimization. Meg?
Thank you so much for that very kind introduction. I think my credentials have been overstated, and Kirk knows he's worked with me for a long time. So anyway, but thank you so much for having me. These are my disclosures, same as this morning, those are the ones in the middle. So for the next hour or so, I wanted to discuss our process for CT protocol development and QI monitoring. So including our team, our general approach, and it looks like a lot of your team is here. Some of the nuts and bolts parameters that we use, some tools we're using for QA and workflow, and then a few example protocols that we've been using. But I wanted to acknowledge the other members of the protocol team, particularly Myron Pozniak, who's now emeritus, but really started this effort and built it into what it is today. And although he's retired, he's still involved, and my junior colleague, Giuseppe Toia here, who joined us from the University of Washington, has really jumped in and spearheaded some of our newer technology efforts around dual energy and deep learning, reconstruction. We have a dedicated CT physicist. We have multiple, but Tim Stigatovich has been the most involved. And he's really been the heart of creating and updating these protocols. And then we have several CT techs, Carrie and Rachel, who worked in our institution for a long time and then joined our protocol team. We actually just hired a third tech. So the need for optimization and standardization of CT protocols has really grown out of a combination of factors that you're probably experiencing in your practice and we experienced in ours, largely centered in the CT milieu of the last several decades, where we see continued growth in utilization of CT. So now, as of 2012, abdominal CT has surpassed abdominal X-ray as most common exam performed in Medicare-age patients. And when we take that utilization and combine it with some of the concerns about the theoretical risk of radiation dose, especially people who get multiple scans, and combine that with intermittent publicized adverse events in the popular media, and put it in the context of the rise of imaging campaigns through places like the American College of Radiology, where we want to image gently and image wisely. And it's always a balance, because we know that if we push our radiation dose too low, then we start to have diagnostic challenges, particularly with low contrast lesions. But we also know that a lot of the time we're doing maybe unneeded phases, or are there ways that we could reduce our dose? And so we've had this longstanding protocol team, this internal protocol project, but it's really the combination of all these factors that led Myron to sort of formalize and create a commercial product from our protocols. And so we've worked with GE and created a commercial product out of our protocols, and it's led to a lot of our QI. And now, we have this added layer of the rise of artificial intelligence, for triaging studies, prioritizing studies, also, extracting data from studies, and the more standardized the protocol set, it seems the more easily these things are implemented and applied. And so that's been a new thing that we've encountered with our protocol project. So at our institution, and perhaps here as well, the most important part of the effort is a robust team. And so we have this fully integrated approach, and our team includes a lot of people. So we have subsection CT leads, every subsection, abdomen, chest, musculoskeletal, neuro, and they're all part of the protocol team. We have these two full-time techs, Carrie and Rachel, who I just showed you, who work in the department and are really experienced with our protocols and our workflows. We have multiple CT medical physicists, but Tim Spikatovich is the one that's been the most longitudinally involved. And then we've partnered with GE, their engineers and their application specialists, and then added some ISO, International Standardization Organization consultants to help us with the QI piece. And then we have a dedicated program administered, Lisa Almond, she's here. And as Myron often emphasizes, we're really supported by an amazing medical physics department, and this has really been an essential part of this effort, because we can say, what we need the protocol for, what our clinical indication is, but Tim and his team do a great job of looking at the specifications of a scanner and optimizing the protocol for every scanner. And our fleet, perhaps like yours, has all different scanners in it. It's very heterogeneous, and so each protocol has to be optimized for different types of scanners. So we meet as a core group, just Tim Spikatovich, our medical physicist, myself, and the techs, as well as Giuseppe. And then the other people are kind of pulled in ad hoc. If we have a problem with a neuro protocol, then we'll pull in the neuro person to discuss the issue. And we've advocated this master protocol concept as a key part of our protocol development and management. And so Tim has used his CT medical physics knowledge to create various dose protocols at different beam energy levels, rotation times, pitches, etc., meant to prevent maxing out of our MA using automated exposure control. And these master protocols range from relatively low radiation dose, relatively high radiation dose, and we try to apply them to different clinical indications depending on what it is that we're trying to glean from the images. So for example, this B7 master protocol, this is a pretty low radiation dose protocol. So we tend to use this for really high contrast tasks, like looking for renal stones, or if it's part of like a multi-phase exam, this is maybe the localizer phase. So enough dose that we can see what we need to see, but not much more. And then if it's a multi-phase exam and we want to look at, say, the liver parenchyma or something, then we're going to use a higher dose master protocol, like maybe B4 for that series. So each protocol, if it's multi-phase, is multiple sort of master protocols cobbled together. This is 1 through 7. There's 14 total options. And then within each master protocol, we adapt it based on patient size. So we have small, medium, and large protocols. This is just a medium protocol dose. And this is kind of what it looks like in pictures. So we increase the radiation dose as the imaging task becomes more challenging or subtle. So we reserve our higher doses, like this full dose exam, for really low contrast tasks where we're looking for like liver metastatic disease or low contrast pancreas adenocarcinoma and abdomen. And this approach has been advocated in several recent studies that came out in radiology, where the authors note that the lack of standardization in CT protocol choice contributes to radiation dose variation. And so in addition to just thinking about a body part, like we're going to image the abdomen, they advocate also thinking about what your clinical indication is and trying to tailor your protocol to that. But one challenge around this concept is that these adequate dose levels are often somewhat subjective based on the reader. And so having some objective, diagnosis-based tasks can be helpful when these protocols are being created. And so once we have all these master protocols, we use it to create tailored protocols for each CT section. So in our section, I'm abdomen imaging and intervention. We have upwards of 25 protocols, ranging from things like a CT venogram or a rule out HCC or a high image quality follow-up, active bleeder, hernia, etc. And so it gets to be a lot, and it's a constant balance between having enough protocols to really address all the clinical questions that are out there, or protocol that can adapt those clinical questions with not having a catalog that's so complex that it's hard to manage. And if you took all of our sections, we have 100 unique clinical protocols across the section. So it's a lot. And then we have multiple different scan platforms that they're adapted to. We take those protocols and we kind of watch the literature to see if there's some way that we should be updating the protocol or changing it. Maybe we need to add a series or do a split bolus instead of a single bolus. Or maybe we need to create a whole new protocol. So for example, Giuseppe Toya, my junior colleague that I just showed you, recently spearheaded an effort to create this CT esophagram protocol. Multiple papers have come out in the literature about this recently, and we've encountered a need for it, particularly at night or at sites where we're not physically present and we need to rule out leak. And so we went to the literature, used our master protocol for non-CT or non-contrast CT chest, but then added some special drinking parameters. And that's worked out really well. I'll show a couple examples later. And then the process becomes iterative. So we do QA and constant feedback and improvement based on inputs from the radiologists, our referring providers, our technologists, and then we have dose monitoring software that's running in the background to make sure that the protocols are behaving in the way they should. We used to have this automatic QA pop-up. You'd open the study. If it was a new protocol, it would ask you just, are the images adequate? You could say yes, no. Once we validated a lot of the protocols, we've tried to pull back on the pop-up because people get so many. Kirk's smiling, he probably remembers it. You get so many pop-ups and interruptions that we try not to use it if we don't need to. And so now we've gone to quarterly QAs with some of our established protocols and we review them all, try to address protocols that repeatedly have issues or get complaints or don't seem to be performing as they should. But with the pop-up, we've collected more than 100,000 responses on the different protocols. So we've tried to vet them very thoroughly. And it's an ongoing process. And then as part of our QA process, we also hold this CT Medical Advisory Board every other year, which Arun alluded to earlier today. And this is where we meet with people that are CT experts from outside our institution in all content areas. So I'm showing just the abdominal experts that have come in recent years, but there's a neuro section, an MSK section, et cetera. And we ask these experts to review the protocols and provide feedback. Are they using something similar? Would they do something different? And normally we hold this meeting in person, but in the time of COVID 2021, it was virtual and that actually worked really well. So probably that's what we're going to do in 2023. But this feedback has been extraordinarily useful to us because we get used to the protocols, seeing how they are. You know, having someone outside our institution look at them has been really helpful. And so we usually spend the months after the meeting incorporating all the suggestions that we get. And in addition, I feel like this has established some really meaningful connections and collaborations with other CT groups that lasted beyond the meeting. And in addition to, this is just the radiology CT medical advisory board. We also have a medical physicist advisory board, a technologist advisory board, and an application specialist advisory board, much of which is supported through our partnership with GE. So every CT has a basic set of standardized parameters based on our master protocols. And you can see that we bin the patients into small, medium, and large based on size. And the way, in an ideal world, we would tailor it to every single patient, but it's hard to do. So we bin them into small, medium, and large based on their size on the AP and lateral scout. So you can see that we make these measurements of the widest part of the patient on the AP and lateral scout, add it up, and then the sum puts them into one of these categories, small, medium, and large. This is usually done, in theory, this is supposed to be done manually. But you can imagine that, you know, people are really busy, so there's a lot of eyeballing that happens. And sometimes, most of the time, you know, an experienced tech gets it right, but sometimes it's challenging when it's busy and we have a lot of new techs. We've had a lot of tech shortage. I don't know if you're having a similar situation here. And so things that can help with efficiency are very appealing. And some interesting tools have come out. This is the 3D camera. Are you guys using this at all? Do you have this?
We have it.
We don't have this. I put it in the budget every year. I haven't gotten it yet. But the NYC is using it. And they put out a couple papers showing that it's really quite good at estimating the size of the patient and centering the patient. And it's much more efficient for their techs. So this is a tool that can help, especially at times when you're busy. We also try to do weight-based contrast dosing, and based on the joint consensus statement that was put out by the ACR and the National Kidney Foundation, we've really tried to streamline our usage. We used to have multiple agents on formulary. We tried to go to just one low osmolar agent and use just one threshold. EGFR is preferred, but we include creatinine too for our inpatients where they don't want to calculate EGFR. We do have an isosmolar agent for the purposes of contrast allergy, but we don't change anymore for poorer renal function, which is something we used to do, but that the paper said there's really not enough data to support. And this has helped us a lot in our workflow as well to go to a single agent. And so we do weight-based contrast dosing for most of our protocols. So you can see that this is just an example for one protocol, patient weight, what contrast we would give depending on the concentration. And most of the time now, we just use a low osmolar agent at 350 for most protocols, which has really streamlined things. We use a smart, a lot of the time when we use contrast, I don't know if you guys do something similar, we're watching the bolus come in. And we use our smart prep images just to QI our enhancement. So this is a plot where we're looking at patients by size and the contrast enhancement from when it's non-con to when it's both-con and how much it's enhancing. And you can see, and this is across all our sites because we want to make sure that we're dosing it in the same way that we're getting adequate enhancement. You can see that most of the time, especially in this sort of middle range, that the enhancement is fairly similar. But in our small patients, we're probably overdosing a little bit with contrast. You can see we're getting a lot more enhancement. And in our large patients, we get an arbitrary ceiling of like 150 cc's. We're probably underdosing a little. So right now, based on this data, we're piloting changing our ceiling and our floor, essentially giving a little bit less to small patients, a little bit more to large patients. And we're circling back to see how that's working. But part of the reason that we wanted to streamline the contrast agent that we used and why that paper was so helpful to us is that we wanted to go to a multi-use contrast injector, and multiple sites have gone to this. Are you guys using these multi-use? You don't change the syringe, you just have one big vat of contrast, you just change the tubing. We, I can't remember exactly when we got them, but we looked at our experience and we found that this is the time spent at the injector. The multi-use syringeless injector, it's just much faster because you don't have to go in and change the syringe every time. You just change the tubing. And when you look at the supplies used, these bottom lines are the multi-use injectors. These are the single-use injectors. So you can see that we just use almost waste no contrast. We use much less plastic waste. The only thing that we use more of right here is saline because you have to prime the tubing with saline. And so it's by and large been a pretty good experience for us. We only have it at our hospital scanners. We'd like to get it at some of the other ones. But several other places have had similar experiences. I was just at Vanderbilt and they also had gotten these recently and have seen a similar experience. In addition, we try to use some sort of dose tracking software to help us keep tabs on our radiation dose, just to make sure that we're falling kind of where we want to be and within established benchmarks. And so for a long time, we used Immulogics. That's what the dashboard that I'm showing you here. I don't know if you guys use this. This was great. We really liked it. Lots of ways you can interact with the data. So you can look at a certain scanner, you can look at a certain protocol, you can look at a location, a technologist, etc. We recently switched over to Calum, so I think it'll be a good switch, but it's new, so stay tuned on that. But here's an example of some of the dose plots that we get. And you can see that these are sorted by small, medium, and large, so blue, red, and green respectively here. And you can see that as the patient size increases, the dose increases, and some of our patients are fairly large. And then it's useful to take some of these benchmarks, radiation dose benchmarks. This is a great paper by Canal et al. That has some benchmarks used for the ACR dose index registry. And we use this to kind of monitor our doses, make sure we're kind of falling in the same range. And so this is a busy table, but it compares our doses at UW to the ACR dose index registry, the 50th and 75th percentile. You can see when you look at all comers in this orange box, our dose is maybe a little bit higher than the benchmark. But when you look at individual size bins, so like if we took this size 29 to 33, you can see that we're actually a little bit lower at a lot of these bins. And I think part of what's driving our dose is that we have more large patients greater than 41 centimeters where there's not as much reference data. And so here we're showing this in a slightly different way. So the Canal references the blue bars, UW is the orange bars. And you can see that the reference has a larger percentage of smaller patients. We have a larger percentage of larger patients. So I think these benchmarks are really helpful, but I think it's helpful to know what patient population you're scanning to give you some context when you're looking at these. And this is kind of what this looks like in pictures. So as the patient gets larger, you can see that the dose increases. So for an 8 centimeter increase in size, the dose roughly doubles. And then you can do the same, we do the same thing with our pediatric patients. So look at our dose distribution, and then you can compare it to established benchmarks. And so after all that, then we circle back to this idea that within a given size bin, a given patient size, that we're going to tailor the radiation dose and the image quality to whatever the clinical task is. And so one thing that we've talked about a lot as a group and that you probably see a lot in your practice as well is metastatic cancer. And so CT has really been the workhorse for surveilling patients with cancer. They may get multiple CT scans over time. And, in general, we've seen a continued rise in awareness and concerns around theoretical risks of radiation, particularly in patients that get multiple scans. And so we've really prioritized radiation dose reduction. And in that effort, I feel like a lot of our cancer surveillance patients have kind of gotten swept along with that. But on the flip side, I think that we know that when we start reducing dose, we may start to lose low contrast liver lesions, which can be really important in the management of cancer patients. And so, we've got some new reconstruction algorithms. The deep learning based reconstruction algorithms may allow us to get away with pushing the dose down, but I think for some of our existing iterative reconstruction techniques, we probably push the dose as low as we can reasonably go without losing diagnostic accuracy. And so this is something that we kind of revisited in our practice. So liver is frequent site of metastatic disease. A lot of malignancies go there. It's really important to detect these lesions as early as we can. And although, we've pushed the dose down a ways, I think if we push it too far, we know we start to lose these. And this has been demonstrated in multiple studies. There have been several phantom studies, including this one, which is from 10 years ago now, from the Cleveland Clinic group, where they looked at a liver phantom with multiple low attenuation lesions of varying sizes. And they found that when they pushed the dose down, that they lost the smaller low contrast lesions, no matter what reconstructive technique that they used. And multiple groups have looked at this in humans too, including our group. We did a prospective human study where we really aggressively reduced the dose in the range of 60 to 70%. And we found that the one thing that we lost was these low contrast liver lesions. So you can see that even at baseline with our best dose, our sensitivity is about 0.9. When we start to push the dose down, even with what were our best iterative reconstruction techniques at the time, we don't get all the way back up to the baseline. And here's an example. This is a patient with metastatic neuroendocrine tumor, and you can see those low contrast liver lesions on the standard dose. You can see that when we push the dose down, they just disappear. Now, things might be changing a little bit. We're still exploring some of the potential of these deep learning or AI-based reconstruction techniques. Studies in phantoms and in humans have been fairly promising compared to some of our conventional iterative reconstruction methods. So the results I'm showing you here are a prospective study that was done in a similar method to the one I just described, where they did standard dose and low dose exams at the same time. And they found that 25 of 31 what they called clinically significant lesions were identified in the abdomen pelvis, and 13 of those were liver lesions. And then several other studies have come out since then, suggesting that you may be able to preserve the identification of liver lesions with some of these deep learning techniques. So I think, it's heading in the right direction, but for example, in our fleet, we don't have a deep learning reconstruction on every scanner, so we can do it on some, but not all. And so I think there's still some value to thinking about radiation dose in our cancer patients. So, we went on to create this dedicated protocol for our patients who have known metastatic disease to the liver or who are at risk for metastatic disease to the liver, and we call it our high image quality cancer follow-up. And this is just meant for anyone who can have liver metastatic disease, so colon, breast, lung, pancreas, all of those malignancies. We boost the radiation dose a little bit, and we don't routinely use it in patients with lymphoma who tend to be young, and we're often trying to identify nodes, which is a lower contrast task. The nodes are surrounded by fat. Usually we can see those better. We don't use it in testicular cancer either, because often we're looking for nodes, and those can be on patients that are imaged repeatedly over time. But a lot of our other cancer patients were using this protocol. And we've been using it since, I think we created it at the end of 2017. So we've scanned thousands of patients now, and we've had pretty favorable feedback. So as with our other protocols, we use weight-based contrast dosing and size-based parameters, but we've decreased the noise index of our routine exam by about 25%, which increases the radiation dose by about 65%. So you can look at, this is what we would typically use for a routine exam in a small patient, medium, and large. You can see that we've pushed it down a little bit in our high image quality cancer follow-up. And here's a few examples. This is an 84-year-old woman, history of breast cancer. She's right on the border of small to medium. And you can see that on her routine exam, maybe there's something there, but there's a liver lesion that we see much better on subsequent high image quality follow-up exams.
What's the time difference between the first one and the second?
These are about 3 months apart. So it's possible that she developed it for sure, but it was pretty stable at the subsequent 6 months. So it makes you wonder, like, if it had been there, we just couldn't see it. And then here's another one. These are routines. And then here's the high image quality. Maybe there's a couple other lesions that we're seeing better. And we could argue about, what's the clinical significance of some of these small lesions? Maybe there isn't any, but I think there's no doubt that we're really seeing small liver lesions better. And then here's one more example. This is a patient with lung cancer, small lesion. We just see it a little bit better on the high image quality cancer follow-up.
Meg, who selects that? Is it the oncologist that requests it for their patients, or is it the resident or faculty or tech who sees the type of malignancy and selects it?
Yeah, it's the latter usually. So our oncologists know that we have it. We talked to them about it when we rolled it out. And part of the feedback came from them because I think the images were getting quite noisy, especially in our small patients. But the decision is made by the protocoler. And at our institution, as we were talking about at lunch, it's kind of a shared duty between the techs and the radiologists, trainees, staff, et cetera. So what we have is kind of a quick guide. I don't know if I have a picture of it in here that has like an indication in what the protocol you typically use. They have colon, breast, pancreas. We choose high image quality. There are some exceptions like our hypervascular metastatic disease, which I'll show in just a second. So like renal cell carcinoma, neuroendocrine tumor, they get a different protocol. So here's that data in a different form. So our routine exams are the green bar here. So this is all our routine exams. You can see it's paralleling the ACR dose registry standard. So this black line is the standard. Here's our routine exams. Purple, yellow, and red are our cancer follow-ups. And this was done with another cancer center, MD Anderson, where they actually have multiple tiers that they use in their cancer patients. We usually do either routine or high image quality. You can see even with our cancer patients, you can see some stratification of dose, different dose tiers for different cancer indications. And as before, you can see that the dose is increasing with size. And so we would say that maybe we need some disease-specific dose registries because maybe we need a different standard, slightly different standard for our cancer patients, depending on what kind it is, compared to our routine exam. And then on the flip side, as I mentioned, we don't use this protocol for lymphoma because we're looking for nodes. Usually this is a pretty high contrast task. So here's, in the prospective study I mentioned previously, we did about 15 lymphoma patients, and this is an example. This low dose image is about a 90% dose reduction, and you can really still see these small nodes and this haziness in the mesentery compared to the routine dose. You just don't need as much dose for most lymphoma patients, although some do have solid organ disease. It's the same thing, but in the coronal plane, you can see all those small nodes. Similarly, renal stone surveillance is a pretty high contrast task. So metabolic stone disease, the stones are almost always calcified. The patients are sometimes medically managed and get multiple studies over time to monitor their stone burden. They use it both to evaluate whether the treatment is working, but also to predict future stone-related events. And in our practice, and maybe in yours, they use a whole spectrum of things to image renal stones. So sometimes they get CT, sometimes they get ultrasound, sometimes they get abdominal radiographs. And so, although we can sometimes identify stones on all the studies, how well we quantify the stone burden is maybe a little bit variable. And we found that probably we can capture the stone burden the best on CT, both with linear measures, but sometimes they're complex shapes, and a volumetric measurement is maybe a better representation of their total stone burden. And we can do that much more easily on CT than on some of our other types of exams like a KUV. And now we have some AI-based tools that can even do this kind of volumetric assessment in the background on CT. So becoming more and more clinically feasible to evaluate stone burden this way. And so as part of that prospective low dose study, we did look at renal stone protocol. We found that we could push the dose really pretty low and still identify stones that were 4 millimeters or larger. Again, we can kind of discuss what is a clinically significant stone. Smaller stones probably we missed when we pushed the dose really low. But reconstruction, iterative reconstruction, and now deep learning reconstruction and coronal images seem to improve our stone detection. So we created this limited renal stone protocol. It's a really low dose CT, and we've limited the Z-axis coverage just to the kidneys. So it pushes our dose down a lot, particularly in our small and medium patients, to the point that it's about the same dose in many cases as a tube-view abdomen X-ray. And then we're able to assign a limited code to it as well, which really pushes the cost down, and it's made it similar in cost to an ultrasound. And we've really tried to move our urologists towards using this protocol instead of doing a CT sometimes, an ultrasound sometimes, et cetera. We've seen pretty good adoption, but what we've generally had to say is that this can only be done in patients who have known stone disease, so they've had a prior flank pain CT. They're asymptomatic, meaning like they don't have any pain, they're not looking for hydronephrosis, because we're not gonna see the whole ureter. And they've had a prior full flank pain CT, so we know kind of what it looks like. Right now, we're just doing unidimensional measures, but we're hoping to be able to start doing this automated volumetric stone assessment in the background. And so we're scanning this pretty routinely for stone surveillance. Only downside is once in a great while, we have to call someone back because they have hydro or they have something that we need to look at in the pelvis that wasn't included. So again,
Sorry about that, interrupt, but you were mentioning that great, similar to radiograph, obviously increased sensitivity detecting stones, but that multiple things would need to be met. They'd have a prior
Yep.
CT scan through the whole thing, not from that. Who decides that all those things are met before it can get put?
well, so that again is like a shared duty between the techs and us. So usually what will happen is you just look in there. You have to look the patient a lot of time to make sure that they have a prior full flank pain CT and that they have known stone disease. So usually that's the main thing that's required is you have to look. And you can also see it in the EMR, so you can look and just see how they had a scan before, or was it a full? And then we usually ask the techs to really ask the patient, are they having any symptoms today? We also, have created multiple teaching materials around what hydronephrosis looks like. And if you see it, please call. We used to check all our stone exams, but that's just so much phone traffic that we don't anymore. But we do, ask the techs to take a look at the images. If they think there might be something going on, we ask them to call us before we let the patient go. Otherwise, we have to bring them back.
I got a question.
Yeah.
So these scans you're doing, like, are those on outpatients, they on ERs, inpatients, or are they on the whole, across the whole board?
Mostly they're outpatients. A lot of our ER patients are coming in symptomatic, so we're gonna do a full flank pain on them, but not always. So I would say most of the time it's our outpatients who are, we've treated medical stone disease, we're doing follow-up on. Once in a while, maybe an inpatient, but usually not.
Yeah, because I can see our ER pushing back hard on just doing that.
We hardly ever do it, for exactly that reason. We hardly ever do it in the ER, because usually they come in with some kind of pain, they don't know what it's coming from, so they don't want us to do so this is mostly for patients with known stone disease where we're following them on therapy.
Okay, let's get that.
So here's an example. This is a 74-year-old male. You can see he had a full flame pain, and then you can see his limited stone follow-up. We still see his stones really well. Much lower radiation dose. And when you look back in his jacket, he had had 26 studies related to his stone disease, all different stuff though. So really estimating what was happening with his stone burden was challenging. We have implemented a couple other limited protocols. We don't have a lot, just this one. And then we have a limited pelvis for inguinal hernia where we have a Valsalva. And again, it's for sites where we don't necessarily have a radiologist on site to check an ultrasound, or if you get a patient that's very large, doing an ultrasound for a hernia can be challenging. And so we have a limited inguinal hernia protocol. But if there's anything else in the history, again, like cirrhosis and inguinal hernia or something like that, we don't use the limited protocol because we won't capture all the pathology that they want to see. And then I'm sure you do this as well, beyond the radiation dose and the total contrast dose, we can change the way we inject the contrast. And so we'll just go through a couple examples of how we change the timing of the contrast. So we have a biphasic protocol that we use a lot. We perform a late arterial phase and a portal venous phase. And maybe everybody does this a little bit different, but we use a smart prep where we watch the bolus come in. We have a Hounsfield unit threshold, and then we trigger about 15 seconds after that. In theory, we use this for hypervascular diseases, and I'll show a couple examples, but mostly renal cell carcinoma and neuroendocrine tumor. And not all the scanners in our fleet are dual energy capable. We have some. If they are, then we try to do it with dual energy because then you can get your low KEV data sets and your iodine material density, but we can't get that on every single patient. And so this is kind of what it looks like. I'm sure you guys have seen this. So we start with non-con, we watch that contrast come in, and then we can use those bolus checking images to assess the enhancement. And that's how we get the quantitative enhancement data that I showed you earlier. So we tend to use it for stuff that we might not see on a routine portal venous phase. So mainly renal cell carcinoma and neuroendocrine tumor. There are some other malignancies out there that are thought to be hypervascular, but this is kind of where we've most consistently seen data. I'm just curious, do you guys do a biphasic exam in these patients?
Yes.
Yeah.
There's been a lot of debate about whether to use it in all renal cell or just in renal cells that are being aged for prior to resection. So in other words, I think we had some debate amongst our section about whether or not to look for metastatic disease with renal cell with the arterial phase. And currently, we are not doing that. We're just looking at the lesion itself and the vascular involvement. Do you look for the metastatic disease or
We do.
how do you do it?
Yeah, we do. For patients who have known renal cell carcinoma where we're surveilling for metastatic disease, even if they don't have known metastatic disease, we do it. But it's a point of discussion ongoing in our practice because there's, you get a feeling that there's a certain amount of disease. I had Gestalt at maybe like 15% where you only see it well in the arterial phase. But it's hard to pin that down in the literature. I'd be really interested to see a more an up-to-date series on that. We used to use it for melanoma, but we stopped doing that, although I've talked to some places that still use it for melanoma. So it's a little bit of a controversial point in our practice, but I threw in a couple examples. So like, I think in particular, the pancreas can be really hard when there's metastatic disease in the pancreas. I feel like sometimes we only see it on the arterial phase. So this is a patient, bilateral adrenal mets. Here's our late arterial. You can see that pancreas lesion. This would be really hard to pick out on the portal venous phase. Here's another case. This was a patient who had 2 liver lesions. So you can see the liver lesions on the late arterial phase. They're pretty hard to see on the portal venous phase. And she also has this pancreas lesion right here. And it's a tough one because it's kind of mimicking the vessel. We didn't see it, even though you can probably pick it out on the late arterial phase. We ablated her liver lesion. She had some bleeding. And so she had an angio. And you can see it on the angio. It's right here. And then you can see that they grew. So here they are, now they're bigger. And again, even at this size, I think they'd be hard to pick out on the portal venous phase. And she's a patient that's refused any therapy. So I just reviewed her conference again this last week. And here you can see her late arterial phase. She's got multiple liver lesions. And now she probably has tumor thrombus in her portal vein, and the arterial phase is helpful. I think we're seeing that enhancement in the portal vein. But you can see her pancreas disease has gotten really extensive. She has disease in her thyroid. So unfortunately, really widespread disease. This is another case, 73-year-old male, had metastatic disease to the liver. You can see his kidney's gone, so we're following him up. Has this enhancing lesion in the liver. Had a single phase exam 6 months prior. Probably it was there, but we didn't see it. So I feel like maybe it optimizes our chances of seeing a certain percentage of disease, but it's hard to pin down exactly what that percentage is. And then I think it can be useful in assessing response to therapy, both systemic therapy, where they're getting some sort of anti-angiogenic agent, but also local regional therapy, where we're looking for decreases in enhancement to suggest that the cells are dying. So this was a patient, 43-year-old woman. She was on cabozantinib, one of our targeted agents that decreases vascularity. It's a VEGF inhibitor. You can see that although her lesion really didn't get smaller, it really stopped enhancing, which makes you think that it's working. And we see it pretty well on the arterial phase. And then this is a patient who had metastatic renal cell carcinoma to the liver. It was really high in the left lobe, which can be a really hard place to see. And this was a large patient. So we treated it. We thought we could see something still up here on the intraprocedural images. So we tried to treat again there. And on follow-up, you can still see that there's something up there. This was done with on one of our dual energy capable scanners. And so that can be really helpful in ablation where you're looking for tissue that's still kind of taking up the eyes. So we don't have it on all our scanners. We have it on a few, and when we do, we use it. And this we followed. It grew. Eventually, we retreated it, but it grew very slowly. So here's a neuroendocrine case. This was an 83-year-old female. She came in with sort of non-specific symptoms. You can see on her baseline exam that she's got a mesenteric mass. Probably she has a liver lesion, but it's kind of hard to see. And then came back and had an arterial phase exam later. It was, I think, 15 months later. And now you can see it much better, both because it's bigger and because we've got an arterial phase. Another case of same. So baseline exam, 12 to 15 months later, you can see the lesions much better, not only because they're enhancing, but also because they grew, because we didn't see them initially. And then again, post-local regional therapy, I think can be really helpful. This is a patient with metastatic neuroendocrine tumor. You can see pre-treatment, she's got this big enhancing lesion. 6 months post, a lot of the enhancement has gone away. So I think it can be really helpful for being confident that the disease is being adequately treated. And then we also do a biphasic CT in the pancreas. So we do a late arterial to sort of maximize our pockets of noise in detecting low attenuation adenocarcinomas, which can be really subtle. So in theory, about 40 seconds post-contrast, that late arterial phase, the background pancreas should be maximally enhancing. A hypovascular lesion like a pancreas adenocarcinoma is not. And so we're sort of trying to optimize our chances of seeing it. The one thing here is that I think that the pancreas is a little bit less sensitive to the timing. So we don't use the smart prep for this. We just do a set delay, and it works pretty well most of the time. The other thing that we use the late arterial phase 4 is looking for vascular involvement. So if there is a pancreas cancer, we want to see how much of the vasculature is involved. We used to do a dedicated early arterial true angio, but then we didn't get a great look at the pancreas. And so we sort of compromised by doing this late arterial. We can see the pancreas lesion, but we can also look at the vasculature. And then we do a portal venous phase to look for disease everywhere else. And again, on dual energy capable scanners, we'll do dual energy CT. Those low energy images can be really good for seeing the pancreas lesion. So here's an example. This is a patient who presented with abdominal pain and a pancreas cancer. And you can see as we scroll through, there's this pancreatic ductal dilation here coming down into this ill-defined mass lesion here. And then you can see it sitting right next to this sort of maximally enhancing pancreas. So sort of improves our chances of, and we see the secondary findings. So hopefully we pick it out, but I think doing the late arterial phase maybe helps us see and measure it. And then this is a dual energy case where these low attenuation lesions can be even a little bit more conspicuous. We also do a biphasic CT in hepatocellular carcinoma, so we know that those are going to parasitize their blood supply from the hepatic artery. They'll enhance on the arterial phase and then wash out when the rest of the liver is enhancing. But in this case, we have a rule out HCC protocol because we're a transplant center, maybe you guys are too, and UNOS requires that you have a 3-minute delay as well if you're going to use it for exception points prior to transplant. So our rule out HCC is basically a biphasic CT, but then we just tag on a 3-minute delay. So we just, take our master protocols, tag stuff on where we need it. And this generally works pretty well. So here's an example. This is a patient who had a really fatty background liver. You can see this enhancing lesion with washout. This is our late arterial portal venous and 3-minute delay. And again, particularly in the setting of local regional therapy, but with any hypervascular lesion, dual energy can be helpful. So she would scan on a dual energy capable scanner. She had multiple local regional therapies. You can see she had a wedge resection, but also multiple ablation, differentiating what's treated from what's viable disease. Having these iodine map low energy images. So we can also split our contrast bolus in order to capture 2 different phases in a single scan. Are you guys doing any split bolus? Not really. It's fallen a little bit out of favor in multiple practices now. So it was first described in CT urography, and what's really meant to do is capture some of the phases, the advantages of a multi-phase exam in a single phase. So, we have a split bolus urography exam. So we do a non-con to evaluate for stones in patients who come with hematuria. We inject 50 cc's, we wait 10 minutes, we inject another 100 cc's, and then we wait 70 seconds and scan. And we essentially get both an excretory and a nephrographic phase. And the upside is that we get 3 phases for the price of 2, essentially. But the downside is some would argue that they're only excreting at 50 cc's. So maybe we don't get quite as robust distension of the collecting system. Although, again, it's hard to find really quantitative literature on this topic. So we have 2 urography protocols. We have a single bolus where we do a non-con, a urothelial phase, and an excretory phase. And then we have a split bolus. We essentially separate people by age. So if they're less than 45, we do a split bolus exam, 2 phases. If they're older than 45 or they have a known urothelial cancer, then we do a single bolus. And that's this non-con 60-second and 10-minute delay. And then again, if we have dual energy, we use it, but we don't have it on every scanner. We don't use diuretics. Do you guys? Yeah. Do you use diuretics for your urograms? Yeah. So here's an example. This is a split bolus exam. You can see this patient came in with hematuria. You can see that there's this infiltrated lesion, upper pole. So this is urothelial cancer in the renal collecting system, and we see it pretty well with the split bolus. We also like to use split bolus in the setting of ablation, where we're looking at the adequacy of our ablation zone, but we're also looking at an injury, looking for an injury to the collecting system. Sometimes this saves time because we give 50 cc's while we're cleaning up, getting the bandage on, then we give 100 cc's and then scan. And we found that this really does pretty well for the purposes of ablation. But as I said, for our patients who are over 45 or patients who have known urothelial cancer that we're following up and looking for recurrence, we do our urothelial tumor follow-up exam, which is a single bolus with 3 exam phases. As an aside, we recently looked at our CTUs. We looked at about 150 patients, and the majority of them were the 3-phase exam. Smaller group were the split bolus, but we found that the split bolus performed fairly similarly to the cohort as a whole in terms of the presence of findings, and there was only one more ureteral mass found in the single bolus compared to the split bolus. So not a ton of data, it's not a perfectly matched data set, but it seems like the split bolus performs pretty well, at least in the indications that we're using it for. There's a lot of other literature out there on split bolus techniques. CT enterography is one that I think is particularly intriguing, but we don't do that yet. I think that this can be really useful, but it increases the complexity of the scan protocol, makes it a little bit trickier to scan. And sometimes I think it makes it a little bit trickier to read because you're getting simultaneously two separate phases at the same time. But there's some really interesting literature. This is an example of a split bolus pancreas that I was just talking about. This was from Olga Brook. They're doing this at Beth Israel. And then I just wanted to spend the last few minutes talking a little bit about enteric contrast and where it's still considered high yield. We're at UW, we're a pretty strong bastion of positive oral contrast use, probably more than most other institutions, but I think there are some places and some special protocols where it can be really useful. So I was talking a little bit earlier about our CT esophagram protocol, and this is mostly used looking for postoperative leaks. So people who are post-esophagectomy or post some other sort of procedure where they have like a dilation and they're looking for a leak. And we scan it as a non-con-chest. We drink them a little bit right before we scan them, and then have them drink just a little bit more on the table. And if they can lie, and we scan them always supine, but if they can lie either on their side or even towards prone, depending on where they're worried that the leak is, sometimes we'll scan them a second time in a different position. And this has really worked pretty well. We've seen pretty high levels of adoption by our thoracic surgeons. We usually do it without IV contrast, although you can add IV contrast if you want. This is a 71-year-old male, had a history of non-small cell lung cancer, had a left lower lobectomy, had a muscle flap and was having a lot of coughing with eating. And so they were worried that maybe he had developed a tracheoesophageal fistula. And you can see that he drank the oral contrast here. So it should be in his esophagus, but you can see this tract coming forward to that left main bronchus. You can see all this contrast in the lower lobe. And so he unfortunately had recurrent tumor here with fistulization. We could see it really nicely, even with a small drink of contrast on the exam. And he was subsequently treated with stents, both in the bronchus and in the esophagus.
And he was supine?
He was, yeah. And the text noted that he coughed every time he drank, so we didn't have him drink the whole amount. But you can see even with a little, we could see it. So for things that are big, we can see him even with a little bit of. This was a 43-year-old male. He had a history of scleroderma and had known esophageal strictures. So they did an endoscopy, they dilated him, they were worried that they had FIRFed him. And so he came for CT esophagram. And you can see that he's got this narrowing where the wall is really thick, but we've got really nice opacification with contrast and no evidence of leak in this case. And so this answered their question. Now here's an example where maybe it didn't work as well. So this was a 32-year-old male. He had chest pain after retching, and he was really tachypnic, like febrile, very uncomfortable. So we tried to scan him as a CT esophagram. You can see that he's got all this gas in his mediastinum in the subcarinal region. It looks like it's tracking down towards the lungs. So very suspicious that he has some sort of leak, but was really hard to identify it because we had so much motion. So he came back for a fluoro exam. And again, it was really hard for him to stand up, like he was breathing really hard, but you can see that he probably has this little leak right here. So, and that was actually stented. So sometimes, for patients who really can't lie down or who really can't hold still, fluoro as a real-time exam still sometimes works better, but definitely for a lot of patients, the CT has worked well. And then we've adopted it into other protocols. So in addition to a CT esophagram, we have a CT upper GI protocol. And this is meant, we get a lot of patients with peptic ulcer disease, they perforate and they get a gram patch, and then they want to rule out a leak after they've been patched. And historically, we've done a lot of fluoro for this, but sometimes the patient comes down and they can't stand, or their stomach won't empty, or they can't drink. Not feeling great. So we created this CT upper GI protocol, but we had a lot of resistance from our surgeons. They said, we much prefer fluoro, and we really think CT is better. And I think there's a lot of literature out there in bariatric populations that CT is probably better for leak, but not so much in this particular population. So currently we still offer both fluoro and the CT. We've been doing this for about a year. And what we do is we have them drink a smaller volume, but denser contrast, and they drink some upstairs. This is largely inpatients, so they're upstairs on the floor, they drink it. We wait 30 minutes, we bring them down, we have them drink even a little bit denser contrast, not so dense that we get a lot of Stuttgart effect, but dense enough that we see it well, and then we scan them. And you can do it without contrast, like you see here, without IV contrast or with. And this was a patient who had had a AAA repair that was complicated by duodenal leak. And you can see the leak really nicely here, the contrast kind of pooling out from the duodenum, very dense. Don't really wonder if it's there. This is another case that I just saw this week. It was a patient who had a gastric perf from an ulcer. They did a wedge resection and sewed it closed. You can see that she has an ongoing leak. So you can see all that extraluminal contrast. It's really dense, probably more than you need to see. And you can pick out right where that leak is here. And then beyond these specialized protocols, we really like enteric contrast whenever we're looking for some sort of leak or fistula elsewhere. So someone who's post-op. This was a 47-year-old woman. She had had dehiscent colon anastomosis that was sort of managed conservatively, and then she presented with drainage from her wound. You can see that she's got all this enteric contrast, and the wound is clearly coming from these small bowel. So small bowel to skin fistula, and enteric contrast just helps us identify it a little better. Here's another patient, right-sided polypectomy. They were worried that they perfed her. You can see right where the hole is because the oral contrast is leaking out. And along those lines, we use oral contrast in our CT colon exams. Are you guys doing much CT colonography or?
Do about 2 or 3 a week. We don't have the kind of reimbursement structure that you guys have in
Yeah.
Wisconsin, so we end up doing mainly completion colonographies or using patients who have respiratory issues and coagulation issues, things like
Yeah.
I don't know if it's reimbursement so much as a referral structure.
that. And referral too.
Yeah, and that has been an issue for us too. I think if Medicare would move to cover it, I think it would change things a lot. But as it stands, we do both screening and diagnostics. So people who have symptoms and have failed optical colonoscopy, but we do try to drink them regardless. And I actually had one of these myself this year. You drink the prep, and then you also drink some iohexol and some barium, and that's meant to tag both any fluid that's left behind and any stool that's left behind. So this is kind of what it looks like. You drink the prep, then you drink the iohexol and the barium, and then it's meant to tag all the fluid and stool. And this is particularly useful for small or flat polyps like this because we found that they can be very hard to see, but something, either the iohexol or the barium, we think it's the iohexol, but we don't know for sure, is coating the surface, and that actually makes them much more detectable. And so my partner, Dave Kim, who's really an expert on these flat polyps, who I call all the time when I'm reading these, has written a lot of papers about this contrast coating phenomenon and how it really helps us find them. So this is another place that we still use oral contrast. And then we use a lot of positive enteric contrast for our oncologic staging. And this is a little bit more controversial. The data has been a little bit mixed on this. So this was a paper that came out in Radiology a few years ago where they basically said, you don't need positive oral contrast in oncology follow-up. This was a paper that came out Michigan group where they asked patients about their experience, and really oral contrast was their least favorite part of their patient experience. And that's true in our practice too. But they also said that if positive oral contrast would improve the diagnostic confidence of the reading radiologist, even 1%, that they would drink it. And so they don't like it, but they'll drink it if they think it helps. And then this is a paper that just came out in AJR in the last year. And they looked at this question again about patients who have malignancy and a risk for peritoneal disease. And they look both at adequacy of filling of the bowel and the negative predictive value of the scan. And they found that if they got neutral agents, they had less, in most cases, less adequacy of distension than if they used a positive agent. And with good distension, with a positive agent, they had a higher negative predictive value. So they suggested that maybe it's helpful in patients that you know have peritoneal disease. So I think the data is not totally sound on this, but this is a place where we still use it. So this is an example. This is a young woman, low BMI, history of cervical cancer. You can see that we gave her positive oral contrast. And here you can see she's got this wall thickening or almost like an eccentric mass right here that would be really hard to see if we hadn't given her the positive enteric contrast. And this was really radiotracer evident. We biopsied it, and unfortunately it was metastatic disease. And then in our ED, we've eliminated a lot of our enteric contrast use. We have a few scenarios where we still use it. And one is this, like really thin patients who have no intra-abdominal fat. And BMI is not a perfect surrogate for that, but that's sort of what's out there in the literature. So for patients who have a BMI less than 25, we still have them drink enteric contrast. And this is an example. This is a young patient, 22 years old. You can see that she had a really nice opacification with her enteric contrast. And you can see that her appendix is big right here. It is not opacified. So this was an appendicitis that we could see pretty well because of the positive oral contrast. That might have been tricky without it. Now this is a different patient. This is a 22-year-old woman that I read recently. Probably would have met our guidelines for enteric contrast, but it doesn't always happen. And you can see as we scroll through here, like pretty hard to tell. Maybe this is her dilated appendix back here, but it's hard to connect it all the way back to the cecum, and it's kind of running right through the adnexa. She had this history of chronic abdominal pain, so we said, we're worried this is appendicitis, but we're not 100% sure. And so she did eventually go to the OR, but they waited 24 hours. She did have appendicitis, but maybe because we used less confident words, it took a little longer for her to go. And this is one thing that we've seen in our practice when we started using less oral contrast in the ED. We found that there was an impact on diagnostic confidence. And this is a table where we look both at faculty and at trainees at 6 months after the change, at 24 months after the change. And you can see that there was lower diagnostic confidence in the group without positive oral contrast, but that it was a more prominent effect in our less experienced readers. Now, on the flip side, we saw everybody move through the ED faster, which the ED loves. And the diagnostic rates were essentially the same between the two groups. And multiple studies have shown that most of the time we're going to see things. Rarely patients get called back when we see something else. And so as it stands right now, we've kept our guidelines pretty streamlined, but I think this decrease in diagnostic confidence is tricky because I think we sometimes end up using different, maybe less confident words, or maybe more likely to recommend another study, and identifying exactly what the downstream effects of that are can be challenging. It's something that we're still looking at. So in summary, I think there's a lot in here, but I think having a multidisciplinary team taking an integrated approach to protocols can be really helpful. Thinking about what your clinical indication is and how you can tailor your radiation dose, but also your contrast injection to whatever that protocol is. And anything you can use for QI, either pop up, a right click on your packs, or even something like your smart prep images can be really helpful to make sure that your dose, your protocols are performing as you'd like them to. So thanks very much for your attention.
Thank you, Meg, for that excellent overview and all the work that your team has done at Wisconsin. Happy to open it up to the floor now to take some questions, and I'll kick it off. Alluded to the fact, and we've had issues as well with turnover of technologists and staff, and increasing burdens on radiologists. We're seeing increasing volumes and complexity in their cases. Much of this, to do well, needs to be tailored and needs to have folks who are vested in that process. What have you guys done during these periods of turnover to keep that culture of understanding the importance of tailoring the protocols to high quality patient care?
That is a really good question. One thing that we did, the Mayo Jacksonville group put out a really interesting paper on having a quality tech. And they did it first in their sonography department, where they had a tech that would review exams for quality and then do education if there were issues. And sometimes it was exams that were being identified as QI. Sometimes it was just random check of certain number of a certain kind of protocol. And I think there's multiple reasons why that's good. In sonography, I feel like doing scanning all the time, it's a lot of physical wear and tear. So having someone rotate as a quality tech one day, I think is helpful. I think the same is true for our CT techs. We're so busy, we're scanning really sick patients. Having a day where they rotate and do QI, especially a senior tech, is really helpful. So we created a position called a quality tech, where what they did is they were scanning and they were working and scheduling and all that, but they're kind of a super user of the protocols, and they review all the QAs, do a lot of education. If we feel like something is being, like I was talking about the active bleeding protocol at lunch today, if the protocol is being overused or inappropriately used, we have them do education at the daily huddle. We also send out bi-weekly updates that go to all the techs. Whether or not they're totally read is questionable, but we do send it out, and we repeatedly send the same message if there's a protocol that's not performing the way we want it to, or that's confusing or whatever. We try to do that. Every time a new resident rotates on CT, we have a whole series, cadre of things. We give a protocol lecture to the residents. Our protocol team also gives a lecture. We also have this wiki document. It's kind of like this living, breathing document that has all the protocols on it. And there's a link to it on the protocol electronic page. So like when you're protocoling something, you're like, oh, I can't remember what this is. You can click it and it'll bring up all the protocols in maybe more detail than even you want. And that's always changing. So, and we have sections for, guidance, how to combine protocols. And, we're always trying to put new stuff on there. And then on top of that, we send out a whole bunch of stuff every rotation. So we're always trying to keep them top of mind. But, I think the biggest complaint is that we have too many, and it's hard to keep track of them all. And so it's always a balance because, now we've also created this commercial product. So we want to have enough protocols that we can answer any questions that might arise, but also not so many that it's impossible to manage. So
Yeah, you brought up a lot of topics. We have a lot of our members, we have, quality techs, we have residents interested in developing protocols and things like that. So I'd love to open it up to our team, Sarah, Mandy, any comments on what we could learn from kind of the Wisconsin team. You guys carry a big burden of a lot of the work that maybe, radiologists could be doing, but you guys do an awesome job of keeping the ship afloat. So we'd love to hear from you guys.
yeah, I'd love to know if there's other stuff that you guys are doing.
I think to me that we're doing a lot of similar things. I think that the big thing that we possibly are missing is a dedicated team to support that effort. Because currently that isn't something that we have, but we do have, our physicists are super supportive. Our radiologists are really supportive. It's just, if that's your dedicated job, it's much easier for that to be a forefront, like for the focus and to really push that, and make a dedicated effort for that to be in the forefront for the technologists.
Yeah, it has been and we try to meet monthly, just the core group. So medical physicists, myself, Giuseppe, and then our techs. And then bring other people in as needed, but it is a lot of time. It does help. I will say the downside is that some of our very good, very senior techs have moved over to the protocol team and that we lose them from our clinical pool. So some of our best techs, it's great because I get to work with them on the protocol team, but then we lose them from our clinical team, which is a challenge too. So some of our most senior people really know the protocols well. They're awesome members of the protocol team and we're very glad to have them, but we really miss them.
With your bigger patients, and you're talking about increasing the volume of contrast, which I've been toying with that in my mind for being.
So Dr. Damer is our modality director for CT.
Oh, awesome.
So what sort of doses are you looking at?
So that's a good question. We're still trying to figure it out. We had set this, we use Omni 350 as kind of our go-to agent. And we had set our ceiling at 150 cc's. And there's really no guidance from the ACR about what the max should be. And so we're kind of slowly pushing it up. I think we're doing like in the 180 range now, but we've said we could probably go as high as 200 if we needed to. Or, we have some very large patients where they're over 500 pounds, et cetera. So right now we've said, we've pushed the floor up to, or the ceiling, sorry, up to about 180 cc's, and we're still kind of collecting data. It's one of those things that's has been a little bit slower because we're trying to do it only at one site and one scanner, just so we can track the data a little bit closer. And so it's variable how many patients of different sizes we get. Honestly, we've gotten a lot more patients on the small end where we've pushed the dose down to about 60 cc's of 350. And I think that that's probably working, but it's a work in progress. But we've thought, we kind of set this arbitrary 150. Now we probably can go as high. There's really no set volume that the PCR puts out as far as I know. So probably go more. We just don't want to use too much. So we've gone to the 175 range and we're going to track that data. We're trying to get 50 patients in each the small and large bin, and it's just taking a long time to get the large bin.
Do you adjust injection rate as well, or just contrast volume?
Well, most of the time it's just, we do adjust the rate a little bit depending on the patient. And Tim has made these great tables, like, okay, here's the amount you want, here's the injection rate that you're going to take. We used to have, before we got the multi-use injectors, we had the injectors that had the P3T program.
That's what I was gonna ask you.
Type in the weight and then it would tell you what to do based on the agent that you had. That's the downside to the multi-use injectors, is they don't have that software. So we've had to make tables that show, okay, here's what you inject.
It calculates it for you.
Right. That's what we used to have. And we still have a couple of those at a couple sites, but we've decided like these multi-use injectors are great, but they don't have that software yet.
So when you're dropping your dose on smaller frame patients, do you just drop the contrast dose, or do you drop the contrast dose and mix with saline to knock the HU down a little bit?
Yeah, sometimes we're adding a little bit of saline. We're still kind of trying to figure out what the best thing is, but you're right, it's a small volume. It goes in pretty fast. And so sometimes we'll do more of a saline chaser, not necessarily mixing it with it, but following it a little bit more.
Because I know on like some of our patients, I've been here too long. I've been here too long. We have a patient, adult patient 80 to 90 pounds or even less, we can get away with dropping the contrast dose sometimes down to 70, mixing with 30 cc's of saline. That way you don't get a CTA looking
Yeah.
routine abdomen scan, and even dropping it down to 60, 40 mixing, and then still it's a little bit bright. So
Yeah,
want to know what you guys did as far as dropping the contrast. If you were just dropping the dose from 100 to 70, or dropping the dose to 70 and then mixing in the rest of the volume.
we've been going as low as 60. That's the lowest that we've gone. Our floor was 80 before.
Right.
And then we're adding more saline, but I don't know if they're running at the same time or if they're running the contrast followed by the saline. I can find out though, and I can find it. But I know
The challenge that we were having was that it wasn't consistent. It sounds like you guys have consistent, like this is the instance when you would do this. I think some of the reason why we went away from that at the beginning, when we first stopped lowering for smaller patients, is like some techs would perceive the patient as smaller as lowering it, some of it were not, and then it wasn't consistent when they came back for exams, so they were never getting the same,
Yeah.
For comparison.
Yeah, we'll see if it's not, then we may need to rethink it. And that's why that Smart Probe tool is really useful. We can look at that, how much enhancement are we getting? And there are a few things that throw it off a little bit. If they have a really fatty liver, sometimes it doesn't work that well, but at least we can get a feel on multiple sites, multiple different scanners. Are we getting about the same enhancement with that or not? And so we'll look at that and see, but we're still trying to get up to 50 patients.
And are you doing smart prep for all routine exams for every patient, or is it a timed delay?
We do, it depends on the protocol, but I would say for most of our exams, we do some kind of smart prep. We have a few that are a set delay. We're trying to move away from it on some. We've got a couple scanners in our fleet that don't do it very well. And so we may move away from it a little bit in the future, but most of the time we're doing some sort of smart prep, unless it's a really specialized protocol like split bolus or, something like that, where we give a set amount and do a set delay. For you guys?
No, because
It's a set delay unless it's delivered.
we'll do like a routine delay unless it's like a renal mass, liver,
Renal mass or endocrine.
CTA.
Okay. And the CTAs and stuff you do both as smart prep or?
Smart prep, yeah.
Yes, ma'am.
Yeah, I would say we use it, and it's interesting, because most of the time, it probably falls in that set delay, like our portal venous, most of the time it falls around 70 seconds. And so we may start to move away from it a little bit as our fleet becomes more heterogeneous. We've got a few scanners that don't do it as well. So we'll see, but right now we do a lot of it.
One of the common indications we get is the pelvic fistulas, rectovaginal and colovesicular. Do you always use segmental contrast for them?
Good question too. Again, that's one where we get a mix of requests for fluoro versus CT. So sometimes we do, like an enema under fluoro. We can do rectal contrast for sure. The downside to doing it under CT is we put the rectal contrast in blindly. So if there is some sort of fistula or leak, you can see like that fistula case I showed you, we probably put in more contrast than we needed there, But yes, we do rectal contrast if they specifically say fistula or something like that. And we try to honor what they order. So if they order a fluoro exam, a lot of the time we'll do it that way. If they order a CT exam, then we'll do CT, and sometimes they'll get anterior contrast and rectal.
Something to consider in that regard is also doing vaginal, it's because of the contained space, with the rectal contrast, just blast right by. And then when you put it in vagina, sometimes you can get nervous.
Yeah, I was wondering if they have like a dedicated, use vaginal contrast. So we don't have anything.
I think you have to write it as a comment. We have buttons for IV contrast and rectal contrast, but if you want something special like rectal contrast, we have a box on our sheet that just says note to technologists. Yeah, we don't have a button for it.
Hey, Drew,
We can add those.
Yeah.
didn't we,
It's just painful.
years ago, have some protocol that we dose patients for like 6 hours?
Yeah, that was the,
Intercolitis or something, was that?
we call it the CT interoclysis protocol,
Yeah.
which is, it's not the same as, when you put the nasoduodenal tube down, pump it in. It was just, we would give a higher,
We give them a large volume of contrast like up front.
and the idea was that it would dilute, it would, over the time, it would, the fluid would mix with the contrast material and you'd be able to see the point of obstruction. But, that was before we had multi-detector CT isovolumetric reconstruction. So it was a kind of different era that we had that. So we don't do that anymore. The one thing I was asking, so the split bolus for the renal ablation protocol, I used that for a while, but what I found was that I can get the same information and have the same time savings with 100 milliliters of Omnipaque, because I do the scan at 100 seconds, standard nephrogram phase to look, and if I saw that there's nothing else that I need to ablate, then I'll go in and clean up everything, and I'll get the 11-minute delay anyway.
Yeah.
It's a little bit more radiation, but then again, it's lower contrast, so.
Yeah, I think whatever works the best for you. We just thought, maybe we didn't need, with our urothelial cancers, we're always worried that there's like some subtle thing. there's
Certainly
something-
urothelial cancers. I was just specifically talking about the renal mass, the
Yeah,
post.
no, I agree. I think that if you do it that way, either way, whenever you clean up, sometimes we would give it, do a few more things, bang it out, and then just do it as a single. But you're right. I think either way works. And I guess the leaks that I've caused, usually they're pretty obvious. So I probably didn't see them either way.
Either way, probably, yeah.
Yeah. Unfortunately for me.
Try to give it the 11 minutes. Also, that's the other thing is if I give it 11 minutes, maybe I'll see it better than I would otherwise.
Yeah, I do think if you have time to wait.
Because we're not going to do anything at that point anyway. We're just going to observe it.
Right. No, that's a good point.
All of our multi-phase protocols have like knock-ons built into them, like the where we have a quad phase, pancreas, we have a knock-on.
Yeah.
Do you think that like adds value to the scans?
Well, that's a really good question too. We still use a localizer, for example, on the liver. And sometimes we've talked a lot about eliminating it because a lot of times you can see the liver edge on the scalp. Not always, but depending on, so usually you can detect it on the scalp. We still have it, and I think sometimes it's useful. We have cut it. We used to do a localizer in our pancreas protocol too, which we've taken out now because we just sort of make sure if we scan the whole abdomen, we're going to get this. So it's a trade-off, like if you really want to narrow your window in terms of what you scan, having a nice non-con localizer, I think can help you limit your Z-axis coverage. But a lot of the time we end up scanning the whole abdomen anyway, because we're looking for something else. We've taken out localizers where we can, but we still have them, for example, in our liver protocol. Could we eliminate it? Probably.
The liver, though, sometimes they're hyperdense.
That's right. I think that.
And then you're just kicking yourself.
Absolutely. And you never know who it's going to be. And then a lot of the time our livers are local regional therapies, and having that non-con, I think is nice. If they've had a taste, it's really high attenuation, if they had an ablation, and there's high attenuation material in the ablation zone. So I think it's helpful. It turns out to be helpful unexpectedly sometimes. We're trying to discuss as a group, as I said, we don't have dual energy on every scanner, but you can make these virtual non-cons, but I have kind of mixed feelings about them. I don't know. Are you guys using them clinically or?
We've moved away from.
We abandoned.
We were.
We've got two factions in our group about that. Some people say they're good enough. I think we should get rid of the non-con. Some people say, I feel like we're gonna miss stuff.
Yeah, we want to try it again, but the first round was not well received.
Yeah.
Well, and I think we were scanning the non-con, for a while, we were scanning the non-con and also doing the virtual non-con, to compare, see like if it was worth eliminating, if we could eliminate that non-con, but I don't think we ever made it to that point where we were.
Had a brief moment of disastrous.
Renal mass. It poses some issues for, larger patients, and it really dependent on the technologist centering the patient well. And like you were saying, like, we also have had a high turnover, and we have a lot of technologists who are very, very new. So, I think we were struggling a little bit with that. That was a lot of, I think, why we were failing for dual energy.
And as I said, our fleet is really heterogeneous. So sometimes we have dual energy available, sometimes not. And so if we don't, then we have to make sure we scan the non-con. And we're worried that it's going to get confusing if we take the non-con out of some scanners and not others, especially when you've got a lot of people. We're just afraid that it's going to be complicated. So we're in a place where we're scanning the non-con and we're making a virtual non-con. We've compared them a lot. And for most things, they're probably okay, but small stones, sometimes they don't subtract well. And as you say, we have, a group that really likes dual energy, a group that really doesn't. So if we're going to eliminate them, we'll really have to ease into it. It's a slow process. We're working that way, baby.
Well, thank you again, Meg, for visiting us. Thank you for your attendance and questions from our technologists and physicists and the rest of our team. One thing that we often do at the University of Virginia as a sign of thanks is to offer up a Jefferson Cup. So Thomas Jefferson is deeply tied with the University of Virginia.
cups were considered key possessions. His teacher bequeathed 2 cups to him. He melted those down, created more cups, and a few of the originals exist in Monticello, but this is a replica. But it's to commemorate your visit, and thank you again for visiting us and giving us these excellent talks. She's got a series of additional talks to give in DC, so I'm going to get her to the train, but thank you guys for coming.
Thank you. Thank you so much.
I'm just